Welcome to all of our attendees. Thank you very much for joining us for the KMT Lowitja webinar this morning. The focus today is on COVID, and we have an absolutely deadly panel for everybody to listen to. Quite frankly, what these guys don't know about COVID probably doesn't need to be known. So, before we start, of course, I would like to acknowledge the traditional custodians of the lands we're all meeting on today and pay my respects to elders past and present. I'm very lucky to be on Larrakia country up here in Darwin. I'm here for the Indigenous Eye Health Conference, and it's beautiful, and I'm actually grateful to be up here on this country. The last time I was actually up here was for the Lowitja conference. So yeah, it's been quite some time. I'd just like to extend all of my acknowledgement to all of the countries you're on. I know that you'll be coming from around Australia and potentially even outside of Australia. So this was and always will be Aboriginal and Torres Strait Islander land. Sovereignty was never ceded. And I'd like to pay my respects to all Aboriginal and Torres Strait Islander people that are here today on the line. We're grateful for you for joining us. And thank you to all our non-Indigenous allies that are here as well. So before we start, I am going to introduce the panelists. And as I said, we have an amazing range of panelists here today. So first up, we have Dr. Lucas Takoka. Sorry, Lucas. He is the first Assistant Secretary, Implementation Primary Care Response. So he works for the government and has been leading the National COVID Vaccine Task Force with the Commonwealth Department of Health, and also the primary care response to the COVID-19 pandemic. So essentially, he is absolutely across both the vaccine program and the primary care system in relation to COVID and other things. So he actually co-chairs the Aboriginal and Torres Strait Islander Advisory Group on COVID. So it's fantastic to actually have Lucas here today. For those that don't know Lucas, if he speaks really fast, it's because he loves his caffeine. I don't know how many coffees you've had this morning, Lucas, but I'm sure you've had at least one or two. We've also got Jason Agostino. Jason is fantastic. He is at NACCHO and is the Senior Medical Advisor. He's also a GP and an epidemiologist. People actually now know what he does as an epidemiologist, the courtesy of COVID. They even know that it has nothing to do with skin. So Jason sits on the Aboriginal and Torres Strait Islander COVID Advisory Group and on the Guidelines Leadership Group of the National COVID Evidence Task Force. He also works as a GP at Yarrabah. Again, beautiful country, Yarrabah. We also have the amazing James Ward. James is up at the University of Queensland. He formerly was at Samari. So I know James from Samari. He's leading the Poach Centre up there. I spoke to James last night, and very much like me, he absolutely loves his red wine, which is brilliant. James has done a lot of work in the sexual and transmitted infection space. He is a Pitjantjatjara and Ngunnawal man from Central South Australia, and as I said, he's the director of the UQ Poach for Indigenous Health. He is an infectious disease epidemiologist, and he has shown an absolute commitment to COVID-19 as a member of the Communicable Diseases Network of Australia, which is the CDNA. And he also was a member of the Aboriginal and Torres Strait Islander COVID-19 Task Force. And absolutely last and not least, we have Dr. Mark Benetton. He's a Kabagabit man from the tribal groups of Southeast Queensland. Look, a lot of you know Mark. He's a GP, a public health medical advisor for the Queensland Aboriginal and Islander Health Council. He sits on the Aboriginal and Torres Strait Islander COVID-19 Advisory Group, and also is the strategic advisor for research and knowledge translation at the Lowitja Institute. And someone once introduced Mark as hot chocolate, and I have to say, we are very grateful to have him here. Now, up next to actually kick off this session, we've actually got Dr. Janine Mohammed. Dr. Janine, as you probably know, is the CEO of the Lowitja Institute. She's a proud Narungga Kaurna woman from South Australia. And look, Janine has been instrumental over the last 20 years in a range of spaces: nursing, management, project management, workforce and health policy. I remember Janine specifically for the cultural sensitivity and safety work that she's done. She's worked in the Aboriginal community controlled sector at state levels, national and international levels, and formerly was the CEO of the Congress of Aboriginal and Torres Strait Islander Nurses and Midwives. Look, I mean, I could talk a lot about Janine, but I cannot not mention that she was an Atlantic Fellow for the Social Equity Fellowship in 2019 and was awarded a Doctorate of Nursing by Edith Cowards University. So Janine, over to you.
Thank you, Summer. And it seems like we've got our favourite drinks happening. So James is my cousin, so I have to say I enjoy a red wine at the end of the day too. So thank you, Summer, and a big welcome to my friends Lucas, Jason, Mark, and my cousin James. And thank you really for being here today to lend us your expertise. As Summer said, what you guys don't know collectively isn't really worth knowing. Of course, I need to begin by acknowledging the people and the country where we're all coming to from today. I'm coming to you from Wurundjeri country. Always was, always will be Aboriginal land. And I acknowledge my elders, past, present, and of course our future emerging generations for whom this particular work is so important. And as Summer said, I'm a proud Narungagana woman from South Australia and the CEO of the Lowitja Institute. And I don't want to take up too much of your time because Dr. Mark, does want to have a good yarn with the panel and you, Summer, and everyone online as well. But I'm very excited and glad to welcome you all here today to what is Lowitja Institute's first KT and Coffee for 2022. So welcome everyone. Look, these series of events, these KT and Coffee webinars are really about knowledge translations, to really gather people's knowledge, particularly the knowledge of Aboriginal Torres Strait Islander peoples, and share that, and to really support collaborative discussions and to generate, ideas for Aboriginal Torres Strait Islander health. And knowledge translation really is at the heart of the Lowitja Institute's works. It's in its inception, and I believe we're the only research commissioning organisation to actually fund knowledge translation in our research projects. And we must do this to deliver better outcomes for our people, whether that's in research, in practice, policy, and of course in community health and wellbeing. So as we all know what a QR code is, but we also know the COVID pandemic has had a huge health and social impact on our communities, which is compounding. And we saw incredible success where our people and organisations, where they were allowed to lead and they were trusted to lead in their own communities. It meant for the first time throughout the first year of the pandemic, at least, our people were 6 times less likely to contact COVID than non-Indigenous peoples. And Lucas and I were talking about it just before we all came online, the actual trust and the power that was given over to Aboriginal Torres Strait Islander peoples. And we were all able to celebrate government and communities and community control in those numbers that came out. And that was internationally, I'm sure James will talk about it, recognise. But, if you want to find out more about that, I recommend you read the Close the Gap report, campaign report 2021, which showcased how that happened in communities across Australia. But we also saw and are seeing critical failures where a lack of listening and planning put mob at grave risk, really, including no responses to long-term critical issues like housing that our communities long warned people in power about. And I'm sure we will learn much today from Lucas, Mark, James and Jason. They're familiar and have been on the front line and know the efforts and know what worked and what didn't work and what we need to think about going forward. Because probably like many of you online, there's part of me that hopes it's all over, but there's just that little thing at the back of my mind where I feel like it's not over, but where to from here and how can we keep our communities safe? And, I suppose the pandemic also raised some opportunities for me. I had lots of time to think about it. And what I did think about was truth telling. Living on Naarm here in Melbourne, I had a lot of time in lockdown to think about the experience of containment and control, and to critically reflect on that and to think about what my people experienced living on missions. In fact, I was born and grew up on a mission for a time, and I'm sure many of the people online either had relatives that were put on missions or, onto outstations, and they were controlled at all times in the name of protection. And for decades, they underwent that. In some instances, for centuries, our people lived in these contained areas. My nana in particular grew up on Point Pearce Mission in South Australia under legislation where it determined when she went to school, when she left school, what job she could apply for, and if she could leave the mission, and who she could even get married to. And that, made the pandemic, I believe, a real opportunity for Australians to stop and reflect, to think about, how that happened to us during the pandemic collectively in Australia, and to think about the many untold stories in this country. People living for their entire lives on reserves and missions and stations right up until the 1960s. And it's also been a time of polarisation, where people were divided. And our peoples are reminded of the impact of surveillance, and through the lockdowns, non-Indigenous Australians got a sense of life without freedom. They got a sense of restriction of movement. Just because, those laws, I suppose, for us as mob, there's legislation that controlled us. Just because those laws have lifted, that doesn't mean that attitudes have lifted, and we need to put those in their right place. And tomorrow, of course, I think about, that we need to recognise National Sorry Day and to raise awareness about that continued effect of those legislations and the forced removals of our families and our peoples, and the compounding and intergenerational trauma. And sadly, that compounding effect is what we're seeing here today with 22,000 Aboriginal and Torres Strait Islander children living away from their parents. And that's why it's more important than ever that we embrace this year's, and Sorry Day is the mark at the start of it, National Reconciliation Week, where we must be brave and make change and seek transformational change of our systems for greater health and well-being for our communities, our families, and, as I said at the start, most importantly, our children. Thank you all for joining us here. Thank you to the Lowitja Institute Research and Knowledge Translation team, which is led by Michelle Kennedy. Michelle is an amazing woman leading that team, amazing researcher. And of course, our very own hot chocolate, Dr. Mark Wenatong, for bringing us all here together today. I suppose that's back to you, Summer. And of course, this is called Katie and Coffee, so I hope everyone's got their coffee in hand.
Thank you for that. And I think it's a fantastic reminder of the history and acknowledgement, obviously, of Sorry Day and Reconciliation Week. And I was absolutely remiss in actually introducing myself. I got so excited by our panelists. So for those that don't know me, I'm Summer May Finlay. I am a Yorta Yorta woman. I'm a senior lecturer at the University of Wollongong. And my background is primarily in Aboriginal community control, and now a baby academic. So that is me. And if you want to know more about me, you can read some of the articles that I've written for NITV, and I'm really grateful to be here. I absolutely adore Lowitja, and as soon as I got asked to do this, I was absolutely saying yes. So now we're going to hear a little bit from Dr. Lucas. So we really want to get a bit of an understanding, Lucas, of how we're tracking at the moment in relation to COVID. Can you share some information with us, please?
Yeah, thanks, Emma, and thanks, Janine, and all the others for the invitation. I'm really pleased to be here. And as Janine was saying, with a lot of very familiar faces and friends that we knew before the war, so to speak, before the pandemic, but then we've been working incredibly closely throughout the pandemic. I'm here on Ngunnawal Dauda, on Ngunnawal country, so I want to acknowledge the traditional owners of this land as well. And recognise all the Aboriginal Torres Strait Islander leaders with us here today. So I thought I'd give just a quick overview of where we're up to in terms of COVID stats and vaccine coverage for First Nations peoples in Australia, and very, very brief reflections on how we're here. So just, I think it's important that we acknowledge from the outset that, and Janine hinted to that the response in Australia has been quite different from other, and the impacts in Australia have been quite different from other countries with sovereign Indigenous peoples, in the sense that from the outset, there was not only, as expected, incredible organising and preparing and leadership from the communities and the peak bodies and the health services themselves, but also a strong partnership with government that came onto the table to make sure that every aspect of the response was done in partnership. So from January 2020, Aboriginal Community Controlled Health Services, other local organisations were already getting ready, developing their own materials, developing their own comms as this new coronavirus was emerging internationally before it was declared a pandemic, before it was declared an incident of national significance. So by the time in very, very early March, where the government and NACHO formed a task force to focus on making sure that every aspect of the pandemic response had First Nations voices, experts and representatives at the table. It was building on work that the community control health sector had already started. So that meant that very quickly we could organise very dark days in March. We were meeting almost daily and developing a management plan for Aboriginal populations. And within 3 weeks, there was unprecedented use of biosecurity powers to restrict travel to remote communities at the request of the community, something that was actually a very significant move, and if not done properly, could have been and still could have some echoes of some of the mistakes of the past and government overreach and oppression. But because it was done at the initiative of communities and in that partnership, was actually seen as a positive measure that did help prevent and delay incursions into remote communities. But the overall approach that everything we did was in partnership and hand in hand, and not just government decided or sector on the outside, but everyone at the deciding table and all the advice and guidance and expertise from NACHO, the peak body's health experts like Mark and James, was going straight into the chief health officers, straight into the chief medical officers, and straight into government policy, meant that we really had unprecedented and incomparable, if you look at the rest of the world, results during 2020 in terms of COVID, when we were dealing with the ancestral strain and then with B117, which was later known as the Alpha variant, which were highly severe variants of COVID. Aboriginal and Torres Strait Islander case rates remain over 6 times lower than the general population. And for over a year of pandemic, we had no one from an Aboriginal Torres Strait Islander background pass away from COVID, while we were having waves over Melbourne in the Melbourne resurgence and a few international incursions through the border. This started to change with Delta outbreaks, and during the first year and a bit of the pandemic, there was hardly 150 cases of COVID in Aboriginal and Torres Strait Islander people, most of them internationally acquired. But then when Delta outbreaks started to take hold in Sydney and Melbourne, and then spread out to Western New South Wales, we started to see higher number of Aboriginal and Torres Strait Islander people coming through with cases, and I'm sure my colleagues will talk about the interaction with social determinants, housing density, and numbers of people living in one household that contribute to some of the increased transmission in Western New South Wales and other Aboriginal communities. But the incredible effort that was taken during those first 18 months to prepare the communities, to develop plans, to close down where appropriate, to have point of care testing available, the comms, the translations, the community-led initiatives, all the videos that were sprouting, and that everyone came together to do with support from government, but leadership from the community, meant that by the time we started to have significant outbreaks of COVID in Aboriginal communities, vaccines were already being rolled out. And in fact, the Western New South Wales outbreak was a big catalyzer to pick up First Nations vaccination rates. We've almost tripled the rates of first doses and double the rates of second doses in Western New South Wales over the period of the outbreak. And then a series of Delta outbreaks in the Northern Territory and Queensland also ramped up vaccination rates. So by the time we were hit by Omicron, which really changed the game for COVID, which is a less severe disease, but with immune escape and transmission advantage with the previous variants, meant that cases exploded, and they exploded all around the country, including with First Nations communities. But by that time, Omicron outbreaks started to take hold in the majority of communities. Vaccination rates among Aboriginal and Torres Strait Islander people, particularly older people, were high, which has helped control the morbidity and mortality. So for the stats, to date, there's been 174,922 cases of COVID-19 in Aboriginal and Torres Strait Islander people. That includes PCR confirmed cases and about 20,000 rat confirmed cases. The immense majority of those have been since December last year. So 164,000 of those 174,000 cases have occurred since December last year, with the subsequent Omicron waves, BA1, BA2, and now BA4 and 5. Unfortunately, that means that 153 Aboriginal and Torres Strait Islander people have died from COVID-19, with 128 happening this year alone. So again, the majority of their burden of mortality from COVID has come this year, but mortality for Aboriginal and Torres Strait Islander people still remains lower than in general population, which is influenced by high vaccine uptake in older populations, but also, of course, a generally younger demographic. So less than 0.01% of cases have passed away from COVID-19, which wouldn't have been the case if the impact was during Alpha or Delta as opposed to during Omicron. Vax rates remain lower than in general population, but it's over 80% double dose for 16 years and over, between 70 and 80% boosted for people 50 years and over, lower for younger people. And now we're starting to see the winter dose for people 50 years and over who have already received their booster, and it's 4 months from their booster coming up. And as of today, we have, apologies, we have had about 13,000 Aboriginal and Torres Strait Islander people 50 years and over received their winter dose, which is about 30% of eligible to date. So there's still a fair to go. We have the vax rates are quite uneven across the country. The 80% is the double dose rate nationally, but there are particular areas where it's lower, there are areas where it's incredibly high. And what we have found, and I'm sure my colleagues will talk to, it's all very localized. You can't make any inference, and we've tried to tailor strategies as much as possible. But one community might have 95% vax rates, and community 10Ks down the road might be in the 40s, and you need to make sure that that community leadership is engaged at every level. That was more than 5 minutes. Sorry, Summer.
That's absolutely all right. It was fascinating. So it was great to get an update. We will allow you an extra couple of minutes because it is really important to remember where we're at. Jason, so from your perspective, as someone who works with Nacho, how are we tracking and what else needs to be done moving into the future?
Cool. Thanks, Summer and Janine for having me. Just starting by acknowledging that I'm on Ngunnawal in Ngambri country and pay my respects to elders past and present. And also, I guess I'm representing the Nacho team here, so I just want to give a shout out to the team, in particular, Dr. Dawn Casey, Emily Phillips, Kate Alexander, and Dr. Maggie Campbell, who have been really helpful, been a big part of the response. And now we have an even larger team. And I noticed that Danella is on the line because I had a peek at the list. And so I'd be remiss to not acknowledge my chair and the leadership that her and Pat have shown through the pandemic. So where we're at, I guess, first of all, I just want to reiterate what Lucas was saying about the importance and the success of the response from the Aboriginal and Torres Strait Islander community. Like literally hundreds of lives have been saved from the actions that were taken early on and getting those vaccine rates up, and by the incredible social and public health response that happened in Southeast Queensland, who were dealing with Delta outbreaks before vaccination levels were high. So they really, truly, at the start of the pandemic, we talked about 1 in 100 people dying, and that would have seen thousands of Aboriginal and Torres Strait Islander people, which would have been tragic. That's not to say that the 153 that haven't died isn't tragic as well. And those numbers sort of need context. So if we just compare it to back to 2019 before COVID, 153 deaths is 3 times what we would normally see in a whole year from flu and pneumonia combined amongst Aboriginal and Torres Strait Islander people. So we've already seen that by May. And if we continue on these rates of deaths throughout the year, COVID will be the 3rd most common cause of death amongst Aboriginal and Torres Strait Islander people compared to that. So I guess it's just to reinforce that we're really not out of the woods. The things that mainly concern me, the one is about under vaccination and the second is about everything else we've got to, all the missed care, I suppose, or potentially missed care. So Lucas talked about the vaccination rates, and I guess what's hiding is that we've got a really under-vaccinated population now. So when stuff was really kicking off in December and January, most people had just had their first or second dose, and that provided really good protection. But as Lucas is saying, a lot of people missed their second dose. So about 5% of the population missed their second dose, mainly younger people. So they're under-vaccinated. And then we know that only about 40% of Aboriginal and Torres Strait Islander people have received a booster. So whilst there was really good protection from the vaccines in December, January, February, there isn't going to be the same level unless people get a booster for June, July, August, when we expect there to be peak COVID cases like there has been in the past 2 years. The other thing that I think trying to focus on is about what care has been missed in the past 2 years. And there is some things starting to show up that I think everyone has experienced themselves, so I think it's no surprise that we're starting to see signs that there has been increased admissions for mental health and for self-harm amongst Aboriginal and Torres Strait Islander people throughout COVID. And there's also pretty clear signs that, particularly amongst young people, we've missed out on some preventative health opportunities, so younger people have been less likely to have health checks. And so there's concerns about what that means for assessing development for really young people, or doing STI checks for our young adults and teenagers. So I think amazing things have happened in the past 2 years in terms of lives protected, but there's still heaps of work to do.
Fantastic. And we might get to some of that work that still needs to be done in some of our questions at the end. James, over to you. One of the things that you and I had a brief conversation about is what needs to be done into the future. So what have we learned from this pandemic, and how do we manage future pandemics or outbreaks?
Yeah, thanks, Summer. And before I begin, I'd like to acknowledge country and acknowledge traditional owners of the land where I am today, acknowledge the Jagera and Turrbal people here in Brisbane, and acknowledge their custodianship of land. I also want to shout out to all the people on this call who've worked extremely hard, and the many others that have been involved in the COVID response to protect our population. I mean, one of the things, and it's kind of a good segue into my first point really, which is one of the things that I've learned over the past 2.5 years is to know that the system, the healthcare system, is much more agile than it kind of portrays it is. And it kind of churns along. It's a normal churn of things. But when we saw this global pandemic, we saw huge changes happen almost immediately across the policy setting, across program delivery, across rollout of initiatives. We saw legislation almost immediately implemented overnight. We saw things like data acquisition, which has been like a thorn in the side of our sector for a very long time. We got very good data about vaccinations, we got very good data about cases almost immediately. And I feel like we need to take the lessons from COVID out more broadly to the rest of our sector, because I feel like we just accept things far too often about the status of things forever. For example, STI notification data with the area I work in predominantly, we don't have good quality data from many of the jurisdictions, but we saw over COVID, we got very good data, which helped us track and monitor and enable interventions to be rolled out in communities where it was most needed over the period of time. So I think that's really important. I saw a lot of cooperation between the states and territories, having said that, and between the community sector, which is unbelievable. And it really demonstrated to me, for somebody who sits on the Communicable Disease Network of Australia, that the cooperation between the states, often there's not a lot of cooperation between states and territories and the Commonwealth. And you see it play out in front of us, and it's often at the expense of our own people. But I saw amazing cooperation between the states and territories and the Commonwealth, and that needs to be carried forward. But it actually puts forward a good case for why Australia needs a Centre for Disease Control, to be honest, because actually it took a lot of people away from the front line, the states and territories. And if we just had a central coordinating agency for infectious diseases and for future pandemics, I think that would put us in good stead. Another thing that I learned from this is that there are a very small number of people working in infectious diseases, blackfellas who are working in infectious diseases. And to be honest, I took a break from COVID the last 6 months because it just kind of, it just took its toll, to be honest. I was on CDNA committees 7 days a week at the very beginning for the first 6 months, and then it was 5 days a week, and then it was 3 days a week. It just really does take a toll on our people who are also trying to do our normal job alongside of our jobs. I learned some other things, like obviously the pivoting of services and programs, and that's been incredible. Like I just seen enormous effort from lots of people running primary care services, running organisations that are looking after the ill health of our people, just pivot and focus in on COVID. And I just want to echo Jason's comments about now we've got to pick up the pieces. We're still not out of COVID. We still have to pick up the pieces from what kind of was put aside during COVID. And I feel like, STIs is really starting to increase exponentially now. We're starting to see that, and that's my area. And but there are probably many other areas where we seen a decreased effort in our normal efforts because of COVID, and we probably need to think about how do we manage COVID alongside picking up the pieces that have been put aside for the last couple of years. I might leave it there.
Thanks very much, James. We might explore some of that further in our Q&A session. So, Dr. Mark, what do you think needs to happen going forward? What do you think are the key priority areas for our communities?
Look, I think we've made some really good inroads. We learned some really valuable lessons so far. There's probably a lot more to learn as well, but certainly that the relationship with feds was so important and tight and quick. And like we're talking about a pandemic, so a week can be a number of deaths in a pandemic if you're organising things too slow. And the issue, I guess, was in the regions that wasn't as fast. So with the state and territory governments sometimes in lots of areas. So, and that was due to a couple of things. One is that we didn't have the health architecture, I should say, structures for leadership for Aboriginal, Torres Strait Islander and Aboriginal community control services with the local regional leads from the HHSs and PHMs, etc. So that wasn't locked in, and I was just listening to we had a yarn up in Cairns last week with the public health mob, and Wu Chopper and the Aboriginal Medical Services saying, yeah, we brokered a deal, but it took us 3 weeks, and it was really hard and challenging because we disagreed on lots of things, but those kind of structures should be in place already, so it's smooth sailing, and there always should be room for Aboriginal and Torres Strait Islander leadership regionally. And so there weren't structures like that necessarily that we could just bolt things straight into in pre-existing relationships. We had to really build that, and that's an issue, I think, for future. And the second thing is probably around infrastructure in rural and remote, particularly public health infrastructure. I think we learnt where the gaps are in that, and I think it'd be really remiss of us not to take that into the next workforce strategy to make sure those kinds of things are picked up that we know, like for point of care testing, etc., tracing and stuff like that. So a few things like that. The other things, we got a lot right, but I think two things were a bit of a worry. One is that we weren't proactive enough with social media and vaccine education. And don't get me wrong, we didn't even know if we were going to get a vaccine at the start. So it's pretty hard moving on your feet. But those kinds of things, particularly the social media stuff, from my perspective, doing community education sessions with whole of remote communities and getting all those questions, will you grow, like, you'll get 3 testicles if you get the Pfizer vaccine. These are the kind of things that were out there, you know, the devil's in the vaccine, or, you know, a whole lot of questions like that. I don't know if we've really explored that enough to understand how influential that was with our vaccine rates, etc., and our ability to respond. But you couple that with the mistrust of government, etc., and then some of the Biosecurity Act stuff, and people start getting really paranoid about things, and probably rightly so. I think it's important for us to be a lot more proactive and think about that in the future. And I think there's a fair bit of research that we could do around what influences were influencing us social media-wise during this phase. The second thing around this is I think it's probably a little bit hard coming from a public health person, but inclusiveness. I thought we kind of lost it a little bit there. So small businesses and stuff like that trying to run, and we're just shutting everyone down, which is the right public health response. But at the same time, I think we've had time now to start really rethinking how we negotiate with a whole lot of things to keep things going and people's businesses and livelihoods going without them being a major impediment to, you know, a pandemic response. So don't get me wrong, I don't have answers, but I'm sure small businesses will, and others. And I think that whole thing around inclusiveness, and when I was doing a lot of the community education, I ended up, you know, I started with inclusiveness, just saying, look, you might not want to get a vaccine at all, and that's your prerogative, but we're health, we still have to take care of you somehow. So we have to work through all this kind of stuff with you and work out the best ways of taking care of you. And the other thing was, of course, you know, the information that we got out was confusing. That was coming from health experts. You know, we had states and territories disagreeing with the feds, and experts in public health disagreeing, and infectious diseases experts disagreeing, and nobody quite sure how effective masks were, and then scientists debating whether a droplet was an aerosol. And so all those things, you know, made people really. And when I talked to particularly community mob about those things, there are things I was kind of worried about. You know, like there was nothing consistent coming through. And my sense was that was more influential than some of the strange social media that was out there that I had to talk to. So those things I think are really important, but I think there's really good learnings from them. And the final thing, I guess, is how we define human rights versus public health emergencies. And how we kind of get that right for our communities and help people to understand that. And lots of times, that's what I was talking to at a community level, you know, that whole thing about this is going back to the old days of coercion and control. And now, and then getting people to think about this as a public health emergency as opposed to an individual human rights issue. But from my perspective, once again, the cultural stuff overlaid was kind of the most useful way of talking to a pandemic, from my perspective anyway, in primary healthcare, and engaging people in what we know is our cultural ways. You know, we always protected our communities, and there was always actually risk associated if somebody else was attacking our communities as well. And you know, being protective was not without risk. And so there's a few things like that, and I think once again, country taking care of us, because that's who we are. So some of those things I think were important messages in social media, and I think one of the things we might need to do is just be a bit more nimble about getting proactive about these kinds of things earlier, before the next one. Touch wood. That's about it from me. Thanks.
No, thanks for that. And for those that aren't aware, Mark was doing absolutely amazing updates regularly from the Punapima when he was in that position. And I watched them, and I have to say they were always really spot on. So thank you for our panelists for speaking. We've got a couple of questions from the audience, which is fantastic to see. I love an engaged audience. Now, if you do have any questions, please make sure you post them in the Q&A. It just helps me keep track of all of them, so I don't want to actually miss any. So, I mean, we've got a couple here, and I know, Jason, you've answered some just as you've gone, and this is for both probably Jason and Lucas. Where can people find more information on the different strains, the number of cases that we've got, and also particularly on long COVID?
Yeah, I can start. So yeah, I posted a few just linking to it's called the CDI epidemiology report. So that gives a national picture of COVID, and that contains some information that we're talking to. It's got a bit of a lag and doesn't have the detail that I guess we at NACHO would like to be public, but it's something. And many of the states do similar reports, and they break it down in that state. And for example, New South Wales has quite detailed, does a similar sort of epi report that contains detailed information about New South Wales. Long COVID's a good one, and at NACHO we're going to host a webinar on it shortly. But the short answer is that there is no real solid information about long COVID in Aboriginal and Torres Strait Islander peoples. I think that's an area we need to understand, particularly given the potential interactions with the already high burden of cardiovascular disease and renal disease.
Excellent, fantastic. Lucas, do you want to add anything to that?
We're looking at ways to improve what gets published in those CDI reports to give a bit more openness about their Aboriginal and Torres Strait Islander data, and the advisory group provides advice on what's an appropriate way of publishing. I also put in the chat the link to the vaccine data. The daily vaccine deck has a couple of slides on First Nation rates that get published weekly, but also beyond those, if you scroll down, every Wednesday we also update Aboriginal and Torres Strait Islander vaccine coverage rates, first, second and third dose, by LGA and by SA4.
Lovely, thank you. Mark, do you want to add something?
Yeah, look, it's just a thought, and I actually sent Janine a bit of an email about this morning, but only this morning. But I just think it'd be worthwhile having a kind of a black source, authoritative source of information about COVID. So it's really hard. Like, you got to look at different websites, and you go to the DO one, and you go to the state one. You can go to the NACHO one. You can go to, there's a whole lot, but nobody's going to do that. Like, hardly any of our mob are going to look at all the sites. Just the idea of pulling together a site that's independent of government, so then people are paranoid about this being kind of government-driven information, but going, this is where it is as far as blackfellas are concerned now, and where we're up to, and this is why things are like they're at, just something with a bit of analysis and then simple talk language, so that people can just access it. Because honestly, that was kind of one of the biggest issues was, I'd give, the DO websites and other websites, but I don't think anybody ever looked there. It was more just having a yarn with somebody. And I think just one source that had a lot of our peaks kind of inputting into that. So they were trusted Aboriginal and Torres Strait Islander health professionals from lots and lots of areas could have input into that as well. But anyway, it's just a thought for at some stage.
Thank you for that. James, is there anything you'd like to add to that?
Just to really concur with Mark, really. A central point that's black and easy and digestible would be really useful. Yeah.
Fantastic. Now, we've had a couple of questions about vaccines, so I'm going to ask all of you. So there's been a comment about vaccine hesitancy and how we go forward. And so essentially, we know the rate's reasonable, but there is room for improvement. How do we actually increase the vaccine amongst our mob? Don't all speak at once, guys.
I'll go first. Oh, you go, James.
No, you go, Jason, you go.
Okay, look, I'll just say, yeah, we recognise it's a really big thing, and I think I think it's interesting how we label it, because Aboriginal, I think as someone pointed in the comments, Aboriginal and Torres Strait Islander people, particularly for childhood vaccines, have exceptional rates, and so I think a lot of it's hesitancy, but I think now also there's this, like, I call it vaccine fatigue, and we sort of talk about that. From us at NACHO, I guess we're just trying to work with the National Centre for Immunisation for resources about how we talk to patients about that are vaccine fatigued or vaccine hesitant. There's actually a skill, and it's a sort of a new one that we're having to develop. So we're just trying to empower our clinicians to have a chat about it. But I think the visibility of vaccines throughout all of Australia is really low at the moment. And I think there also needs to be something to lift the profile of boosters and the winter doses before winter comes.
Yeah, I mean, vaccine hesitancy is one thing. I mean, I think we can't have this conversation without the vaccine elitism discourse that was in Australia, and it was largely driven by leaders of this country, to be honest, saying that one vaccine was better than the other, and it kind of confused people quite a big time. And I feel like people have got a preference now for vaccines, and it's available. It's always available now. But I think vaccine hesitancy is one thing, but I think available, trying to navigate a system, even for a person like myself, to book in to get a vaccine is kind of a bit clunky. And I would like vaccines to be available at everywhere, every day of the week at our chemists. That's one thing that did improve over the period of the vaccines. But the other thing is like people are getting jaded, I feel. Like all of a sudden you had to have a booster, now you have to have another booster for the flu season. People are kind of thinking, how many more boosters? So that's what I get amongst my own friends. How many more boosters do we have to have? And I feel like we need to be, there needs to be kind of some clear direction about, whether it's an annual booster shot or for the next 6 months, it's this shot, and then maybe from there on, it'll be a booster shot like your flu shot every year. I don't think that's been explicitly stated yet, but I think that's where we need to kind of get the messaging, because I feel like there's a lot of uncertainty about vaccines and how many more we'll need to have into the future.
Absolutely. I think that's a really good point. It's not just hesitancy, it is also about access. I certainly know in New South Wales, there was sometimes not enough health professionals to actually give the vaccines, or quite frankly, there wasn't enough vaccines. Greater Sydney outbreak, I know that New South Wales shifted the vaccines, particularly from Western New South Wales, and we saw an outbreak there. So I think it's really good to remember it's not just Aboriginal and Torres Strait Islander people's hesitancy. And Lucas, I see that you've got your hand up.
It's good that we have a bit of debate, because otherwise James, Mark, Jason and I always agree on everything, and it's a bit boring. There is no access issues at the moment.
No.
There was at the peak of some of the outbreaks and when we were rationing based on phases, and definitely last year when we were supply constrained. But at the moment, even from an ease of access, like people can walk into pretty much any pharmacy around the country, or any ACHO, or GPs normally require bookings, which can be a barrier. But the moment pharmacies started to offer mRNA, for instance, at the moment what we have is a lot of unused vaccine in shelves. Now, this is not an Aboriginal or Torres Strait Islander issue. This is in general. We are seeing a degree of vaccine fatigue or vaccine complacency, which makes sense. I mean, we are seeing a growing number of people in the so-called not up to date category. So there's people who had their second dose more than 6 months ago and haven't had a booster yet. But we estimate that about 1 in 4 of those have had COVID in the last 3 months. And ATAGI recommends that people now wait 3 months between COVID and getting the vaccine, so you maximize the impact of that booster. So I think there's a little bit of to unpack on that. Our main concern would be low booster uptake in older cohorts, and luckily that's pretty good. We would like it to be higher, but in general population, we're talking about the 90% booster uptake in 60 pluses. Aboriginal and Torres Strait Islander a little bit lower, but also in the 70s and 80s. What we are seeing is very low or relatively low booster uptake in younger people, of which many have had COVID recently. Many have had an experience of mild disease, and I think it's how we explain that just because you had it and it was mild for you, it doesn't mean that that's going to be the case, and you still are recommended to get your booster 3 months after your infection. And sort of changing that narrative from long-term protection from severe disease versus the initial, you get the vaccine to cut chains of transmission, because that's where the futility of it all comes in. Like, okay, so do I need a booster every 3 months? Because every 3 months my antibodies go down and I can get infected again. But the message is actually the vaccines protect really well and over time against severe disease. Populations at higher risk, older people whose immune system is not as strong, or immunocompromised people are getting a winter dose to make sure that we keep that protection against severe disease. For young people, it's just to make sure that there's that baseline of severe disease protection. But I think we are moving away from using vaccines to cut transmission chains, because it looks like, at least with the vaccines that we have now, that in order to do so, we would have to revaccinate every 3 months. And that is not a scenario where we either want to be or the population will accept.
Thank you for the clarification. I should have pointed out that I did mean that there were vaccines moved in early stages, and at the moment, although having said that, though, there have been a few people talking about access and what that means, i.e. is there enough health professionals out in remote communities, or do people feel comfortable going to their local health service because it may not be culturally appropriate? So while there may be vaccines, there might be a range of reasons people may or may not be getting the vaccine. Moving on for vaccines, because I think we could probably spend the whole hour talking about that. There's a bit of interest in your comment around, James, about burnout, and also recognising that as Jason and I think Mark also pointed out, was that because of COVID, there has been a number of other health issues have not necessarily been addressed, so there'll be an additional burden on health professionals. How do we manage burnout, particularly with our health staff in Aboriginal and Torres Strait Islander communities, to ensure that our mob continue to get the best quality healthcare possible?
Oh, look, I'll just say a broad comment, really. It's not my area of expertise, but really what became apparent was a missing third workforce that was required, particularly in remote areas. So we have two workforces that do locum swap over in a large number of our remote services. When people were prevented, they had to be in quarantine 2 weeks before they come out. There's really a need for a third workforce. And I feel like that's there needs to be a really solid look at remote workforce. There needs to be a really solid look at how do we improve the number of Aboriginal health practitioners and workforce, which many people have been saying for a long time. But also I think we need another solid look at how do we build capacity of the infectious diseases workforce to work within our communities, Aboriginal people, over the longer term. And I think that's a really important missing piece of the puzzle. There's very few people working in the space. There are lots of generalists and lots of people who know lots of things about Aboriginal community control, but there just needs to be a few more, quite a few more people in every state and territory, kind of in regions with public health, infectious disease, outbreak kind of potential. We've already seen a major outbreak with syphilis, and very few Aboriginal people are involved in that one as well. So just kind of, I feel like there needs to be a solid look into workforce, as there does need to be into social determinants of health, and workforce is definitely at the top of this list, yeah.
Thank you. Does anyone else want to comment on that?
Just to say, I agree with James.
Awesome. And James did touch on that before, looking at potentially having a CDC, which I know is something that has been advocated by a number of organisations. So fantastic. Look, we've only got a couple of minutes left, and one of the things that's come up a number of times in the chat is what are the lessons learned? So I'd really like to hear from each of you. What is the one thing that we think we need to do differently going forward? We recognise COVID was an evolving space and that we were literally learning on the fly. So what is the one thing that you think needs to be done differently with the next, hopefully not too soon, pandemic? I'll start with you, Mark.
Thanks for that. Look, yeah, I think, well, there's one macro issue, I think, and that's around self-determination. If we learn that lesson that we can actually trust our Aboriginal communities to give us good advice, I think we could solve a lot of Aboriginal affairs tomorrow if we acted the same way as we have done in this, which was government saying, hey, and Lucas saying, hey, okay, what are we going to do about this? Not, this is our plan, what do you reckon about it? There was trust, and that's kind of missing lots of the time. But I think that's a big lesson to learn. I think it's a big lesson to learn for Australia and for our, Aboriginal and Torres Strait Islander affairs overall. Can actually trust what communities say. May not have all the technical stuff, etc. That's somebody else's business, but you can trust the leadership around trying to do the best things for their local communities. It'll map up to macro policy that's useful as opposed to business as usual.
Jason, over to you.
Yeah, cool. Thanks. So I guess Mark just talked about priority reform 1 of the National Agreement on closing the gap. So I'll talk about priority reform 2, about building the community-controlled health sector. And it's sort of astounding how amazing many community-controlled health services have been in their response to COVID. And we've sort of alluded to all these things that they've done, from public health messaging to becoming like testing centres now with point of care, PCR, and even having access to treatment, and all these social supports that we're following up. And essentially, you know, these institutions are public health powerhouses and replaced many of the functions that were normally done by public health, state-run public health units. But that's been done in addition to what we do, and that's that third workforce thing and the burnout stuff that's been done. So we really do need to recognise that Aboriginal community controlled health services are the only place where public health and primary health care is done properly, and to invest in them to continue to do those public health functions well, including in emergencies like has happened now. So that's the big thing that I think we need to take from you.
Excellent, thank you. Lucas.
Sorry, I'm muting. Yeah, I agree with what our colleagues said, and I think I mean we are yet to have a formal health minister sworn in. We have an interim cabinet with 5 ministers sharing ministerial portfolios. So of course, while we're out of caretaker, it's still early to talk about government commitments. But there's a general sense that the blueprint of the partnership in the advisory group, which was built on the principles of the refresh closing the gap agreement prior to the closing the gap agreement being signed, but with Nacho's leadership and Don Casey's leadership and experts like James and Mark, we wanted to make sure that those 4 priority reform areas were the sort of guiding principles of the work of the advisory group. The Australian Health Protection Principle Committee, which is the committee where all the chief health officers sit on and has been the lead in pandemic policy, has absolutely recognised the value of that way of engagement. So the next stage for us is looking into how to translate the lessons learned from the way of engaging in the pandemic, which we're actually building on some of the early partnerships in the context of syphilis and the response to the syphilis outbreak that James and Dawn were also very involved in, but how we translate that to ongoing engagement in health protection matters when they relate to First Nations people, and absolutely agree with what the others said, that we talk about co-design, we talk about partnership, and it's all very buzzwordy and not always meaningful, but this approach of, hey, we've got a joint problem, we've got the resources and the regulatory capacity, you have the expertise, the trust and the leadership, let's put everything on the table, share openly, not keep our cards closed, and actually design something together instead of cooking something up in a bureaucratic office and then sending to you for some last minute comments. Works a million times better. It's not just morally right, it's actually more efficient. So we definitely committed to continuing to work in that way.
Thank you, Lucas. James, what's your learnings?
So really, I'll just say these. Partnership was absolutely critical. Community intelligence fed up was absolutely critical. And that was early in the piece. The amount of intelligence we got from people working in regional and remote areas was astounding, and kind of helped shape every single policy there. On reflection, I feel like, you know, we know that we've got a vulnerable population, and we know that it could have caused great devastation in remote communities. We probably were a little bit overcautious, and that kind of impacted people and being locked down for many months. But, you know, in hindsight, was it the right thing to do? Was it not the right thing to do? It's something for reflection into the future. And it kind of goes back to an earlier point about human rights issues in a pandemic. And then finally, I think a challenge for us, and I'll be honest about this, a challenge for us was trying to, the balance of trying to look after the most vulnerable communities in Australia in the early days of the pandemic, and those without infrastructure, those without testing facilities, those with that would have had to be air-vacked out, those that would have been an outbreak in an absolute remote community overnight, and we would have lost a whole lot of people. We really did focus on remote, and probably were, probably didn't have enough focus on urban and regional in the early days. We soon pivoted to that when the outbreaks did occur, but we had good infrastructure from the most remote communities in terms of policy and where we needed to go to. So it's kind of I don't know how to do this in the next pandemic, but trying to look after all communities, which there are so many across the country at the same time, and all of them need nuanced responses. So trying to make sure we've got, whether it's a remote focus and then a regional focus and an urban focus in future, may be a way forward. But, there are many similarities between those, but there are nuances in each of those areas. So, it's all very easy to say these things in retrospect, but, they're kind of things that we probably should have a good debrief about someday down the track here.
Fantastic, thank you. Thank you to all of our panelists for joining us today. It certainly has been fantastic to hear about where we've come from and where we need to go in relation to COVID and the learnings that might apply to other pandemics. Again, thank you to Loacha for putting this KT and coffee together. I hope you have enjoyed both your coffee and the presentations. I wish we had more time with the panelists, but as it is just 1 minute after our closing date, I just want to close out and say the two learnings that I really have taken away from this is that collaboration, when you see something like this between government and also the Aboriginal people and sector, can work really, really well. And as Lucas said, I think as someone said, I think James actually, things can actually happen fast, and sometimes I think that's something that doesn't happen very often. So it's good to see that it could happen with COVID, and that there's been a lot of learnings from the COVID outbreak that can apply for the future. And I think we need to, as James and a couple of people said, need to think about that third workforce and make sure that we are supporting our mob going forward. So thank you very much. Thank you for the panelists for joining us. And again, everyone have a really good day.
Thanks.